Now we're going to be talking about the glomerular disease and especially acute post-strep glomerulonephritis and nephrotic syndrome in children. This kind of gives you a picture of the pathophysiology, which is on this picture. You can see it better on page 468 in your book. But it gives you the picture of an acute post-strep glomerulonephritis, and it kind of mimics the same thing that I did on the board the other day with the adult glomerulonephritis versus the nephrotic syndrome. This gives you the alteration in the glomerulus. This is for nephrotic syndrome, and that is on page 471 if you want to go over that. But it's basically the same as for the adult. When you look at the post-strep glomerulonephritis, you're looking at that antibody formation of that bacteria and antigens that form the antibodies, the immune complexes that inflame the glomerulus, and then they damage the capillary walls. And that leads to ineffective filtration, which causes the enlarged kidneys with sodium, water, and waste retention, and then the edema that's accompanied it. Versus the nephrotic syndrome, where you have alteration in the glomerulus and the protein, you have plasma protein, which is lost in the urine through that damaged glomerular basement membrane, which leads to proteinuria, and then you have hypovolemia, because the intravascular fluid migrates into the interstitial spaces, which causes increased in renin production and increased excretion of aldosterone. Then you have reabsorption of sodium, elevation of the cholesterol and the triglycerides, and you have edema. So it kind of goes on the same hand-to-hand pathophysiology as the adult. These next few slides are going to, on the left, as you look at the slide, you'll see acute glomerulonephritis, and on the right side, you'll see nephrotic syndrome. So I'd like to start with acute glomerulonephritis, and we're going to be talking mainly about acute post-strep glomerulonephritis, which is the most common type of glomerulonephritis, which is characterized by the onset of hematuria, proteinuria, hypertension, edema, and renal insufficiency. It occurs as an immune reaction to a group A beta hemolytic strep infection of the throat or the skin. Disorder is usually frequently seen in children with ages ranging from 5 to 12 years, and is rarely ever seen before 3 years of age. The clinical symptoms usually develop 1 to 2 weeks after a strep pharyngitis or 3 to 6 weeks after a strep skin infection. Whereas nephrotic syndrome refers to a kidney disorder characterized by proteinuria, hypoalbuminemia, and edema. And it can be classified as either primary or secondary. Primary is also called minimal change nephrotic syndrome, results from a disorder within the glomerulus of the kidney, and is the most common type that you'll see in children. A child can also have what they call an acquired nephrotic syndrome as a result of a systemic disease such as hepatitis, lupus, heavy metal poisoning, or cancer. So as I said before, acute glomerulonephritis is caused, have that strep infection that occurs before it, and they have this formation of antibodies in response to the strep bacteria. And with nephrotic syndrome, we have an insult that occurs to that glomerular basement membrane. Damages can cause increased permeability and loss of substances that would normally prevent negatively charged proteins from crossing that membrane. Remember that those antibodies, I think I already said this in the other slide, but this kind of slowly gets you into the patho. Antibodies combine with that bacterial antigen to form those immune complexes in acute glomerulonephritis. And then that antigen-antibody complex becomes trapped in the glomerulus and activates an inflammatory response in the glomerular basement membrane. Whereas nephrotic syndrome leads to an increased clearance rate for albumin. This causes a loss of plasma proteins and huge amounts of protein in the urine. So, which then also leads to that hypoalbuminemia, which reduces the plasma onconic pressures. So with acute glomerulonephritis, this inflammation causes damage to the glomerular capillaries and reduces the size of the capillary lumen, which leads to a decreased glomerular filtration rate. So we'll have a low GFR in these children. Whereas nephrotic syndrome causes a shifting of that fluid from the intravascular space to the interstitial space, and we talked a little bit about this the other day. So that fluid shifts reduce intravascular volume, causing hypovolemia and decreased blood flow to the kidneys. So with acute glomerulonephritis, it'll lead to renal insufficiency. It can cause sodium and fluid retention, leads to edema and oliguria. And usually that edema, I think your book goes over the edema is usually worse in the morning and affects primarily in acute glomerulonephritis the eyelids and the ankles. It can be accompanied by decreased urinary output, and hypertension can be severe. With nephrotic syndrome, in response, the renin production is stimulating, causing increased excretion of aldosterone. And aldosterone, as you know, will increased aldosterone in the bloodstream will then the renal tubules will reabsorb the sodium, which causes more water retention and in turn leads to more edema. So this slide just kind of goes over the differences between acute glomerulonephritis, the signs and symptoms, and the ones that you'll see in nephrotic syndrome. Usually in acute glomerulonephritis, you'll see hematuria, tea or cola-colored urine, hypertension, edema, which is usually worse in the morning, is usually facial, and usually in young school-aged children, but older than 3. The clinical signs and symptoms of nephrotic syndrome include are proteinuria, that frothy urine, lots of protein, edema, lots of edema, not just facial edema, abdominal pain caused from the edema, weight gain, hypovolemia. Usually they're normotension. That means that their blood pressure is usually normal. Their pallor, they can have pallor, fatigue, and they're usually a toddler or preschool age. So with our diagnostic evaluation, we're going to do a history, our presenting symptoms, renal ultrasound, urinalysis is all done for acute glomerulonephritis. Usually nephrotic syndrome is based on the history, clinical manifestations. Also, we would want to do urinalysis on both just to rule out either one, especially for the hematuria versus proteinuria. Elevated BUN with our acute glomerulonephritis. We'll also have elevated erythrocyte and sedimentation rate, that's inflammation. Elevated ASO titer, that just means that we're positive for strep. Elevated creatinine, electrolyte imbalance. Versus our nephrotic syndrome, our lab results will have a urinalysis which shows 3 to 4 plus protein in the urine, and possibly you can have some microscopic hematuria. we will have hypoalbuminemia, elevated cholesterol, our triglycerides, our elevated hemoglobin hematocrit, and our elevated platelets. Very important. On therapeutic management on acute glomerulonephritis, it's basically supportive. We want to give antihypertensives, diuretics, and they'll be on a low salt diet. A nephrotic syndrome, we usually give prednisone. Let me go back to acute glomerulonephritis. They're going to go ahead and, if there's still strep, if they've done strep cultures of their throat, or if there's a skin lesion and they still haven't cleared, they may put them on some form of antibiotic as well. Nephrotic syndrome, we're going to give prednisone to initiate their remission, also diuretics, and possibly administration of salt-poor albumin, which then will pull, it pulls the proteins in the interstitial space back into the intravascular system. Antibiotics to prevent infection may be ordered, and they don't add any salt to the diet. So especially those, mamas, we got to teach them, not to add any table salt and keep them on that low salt diet. Our nursing considerations with acute glomerulonephritis, we're going to maintain I&O every shift, daily weights, and make sure that our infants are naked, and make sure our older children only have a gown on. Monitor cardiopulmonary status every shift, and fluid restriction is ordered. A lot of times this says every shift, but we may be doing every 2 to 4 hours, listening for any crackles, especially if they have fluid volume overload. Make sure on our nephrotic syndrome children, we position change every 2 hours because of the edema. Good daily hygiene, support and elevate those edematous body parts with pillows, and they will have physical activity as ordered or as tolerated. So we want our acute glomerulonephritis, as I said before, the low salt diet, clustered care to promote rest, because if they're napping and resting, we don't want to wake a sleeping child. Frequent position changes to decrease position on body prominences. Antibiotics is ordered for our nephrotic syndrome, vital signs every shift, I&O every shift, monitor our lab values, and observe for signs of dehydration, and make sure that we do those daily weights, which are important. So with our glomerulonephritis, good daily hygiene is for both. Monitor for signs of dehydration. Vital signs are important, probably more than every shift, but probably every 4 hours. And we want to make sure that we teach our parents how to take care of their children while in the hospital and when they do go home. On nephrotic syndrome, we don't want to add any salt to the diet. Measure that abdominal girth daily, especially if there's still edematous. Administer diuretics as ordered, and monitor their lungs and their heart for any fluid volume overload, and make sure that we teach our parents how to take care of their children. Your book has a wonderful nursing care plan for the child with nephrotic syndrome, and that's on page 472 to 474. If they do go home and they've maybe had a stay, in the hospital or nephrotic syndromes, we want to make sure that we teach the parents how to measure the abdominal girth, how to give the diuretics, make sure that we teach them the work of breathing, the breathing hard, that they may see nasal flaring or those intercostal retractions. Make sure that that you incorporate the parents in the child's daily care, including urine protein testing, assessing for edema, and then arrange for probably dietary consult. Steroid therapy usually stimulates appetite, so the parents should be informed about some low-calorie snacks. Portion size is important. And make sure that the parents know how to maintain a daily calendar of urine protein readings, and make sure that they know how to perform good hand hygiene and other actions to prevent infection. And as we evaluate these children with nephrotic syndrome, we ask the parent to describe the child's condition and the required treatment. Did the parents actively participate in that child's care? And can the parent, before they go home, demonstrate procedures that will be required of them at home? So, because a lot of them will be in the hospital just maybe 2 or 3 days, and then they do go home as outpatient and go back to their pediatrician. This is a little one, Daddy's caddy. It's so cute. This is a child with nephrotic syndrome. As you can see, the little face is very, very swollen, and usually it's more swollen in the morning, maybe more dependent, as the day goes on. So those are all things we have to watch for with our children with nephrotic and acute glomerulonephritis. Now we're going to be talking about Epispadias and Hypospadias. And Hypospadias is a congenital anomaly in which the actual opening of the urethral meatus is below the normal placement on the glands of the penis. And the degree of the misplacement of the urethra opening can vary. It can be may only be slightly ventral to the glands or as far back as the penis and the scrotal junction. Cont'd or that downward curvature of the penile shaft is usually seen in more severe cases of hypospadias. And there's some associated anomalies, which include undescended testes and inguinal hernias that can also be present. That dorsal placement of the urethra opening, or epispadias, can also occur, but it is very uncommon. Hypospadias is one of the most common congenital anomalies, occurring about 1 in every 250 male children. The risk is increased if either the father or a sibling has the anomaly. Some other contributing factors include maternal age, over 35 years of age, intrauterine exposure to environmental chemicals, and possible genetic mutation. Testes are undescended in about 10% of the affected children, and the risk for inguinal hernia is increased. Epispadias is extremely rare and is often associated with bladder exstrophy. So in our clinical manifestations, we'll have ventral placement of the urethra opening, altered urinary stream, and cont'd are physical manifestations of hypospadias. A defect on the top side of the penis is indicative of epispadias, and the appearance of lower urinary tract structures outside the abdominal wall is seen with that bladder exstrophy. Diagnosis is usually based on physical exam. Therapeutic management is surgical intervention. It's usually done in one stage. They have the release of the cont'd and the lengthening of the urethra, repositioning of the meatus at the penile tip, reconstruction of the penis, and it's usually done between 6 and 12 months of age. It's important that you remember that no circumcision of the infant should happen with hypospadias, because what's going to happen is the surgeon will use part of the skin when he does the circumcision for the hypospadias repair. The therapeutic management, as I said before, is surgical intervention done in one stage. Usually they'll have a stent or a catheter in place after surgery, and keep in mind that they'll have the goal of surgery is to make urinary and sexual function as normal as possible and to improve the cosmetic appearance of the penis. This is just a little discussion question. If the nurse is teaching parents of a neonate who has a child born with hypospadias and the parents ask you how come their boy cannot have a circumcision, how should the nurse respond? And basically it's the foreskin will be used during that reconstruction of the penis. So that will definitely relieve those parents' minds, especially if they want their child to have a circumcision. So anytime our children are undergoing surgery, we would like to provide a surgical tour, especially in the wake-up room, determine the child's words for penis, urination, etc., encourage the parent to remain with the child as appropriate, provide that support and reassurance, assist the child to cough, deep breathe, frequently reposition infants, perform frequent vital signs, and teach splinting of the incision and incentive spirometer preoperatively. Assess and monitor for any bladder spasms and incisional pain, provide analgesics as ordered, regulate IV fluids, keep strict I&O, so measure daily weights, teach the need to keep the skin dry and odor-free, and provide any written instructions to parents, and also to provide any kind of contact number if problems occur. We're always looking to make sure that we provide a high fluid intake to maintain hydration and a flow of urine, and we need to teach the parents to monitor the child's temperature and observe that urine for any cloudiness or any foul smell. Any signs of UTI should be reported immediately, and sometimes they will order prophylactic antibiotics for the child or the infant. Okay, I think that's it. And then we'll go on to our glomerular nephritis and nephrotic syndrome in children. Cryptorchidism is undescended or hidden testes, which can occur one or both testes that fail to descend through that inguinal canal into the scrotal sac. Congenital cryptorchidism is a common neurological problem, with approximately 4.5% of normal healthy boys having at least one undescended testis discovered at birth. Premature infants have a significantly higher incidence, and that's about 30%. It's usually seen more frequently in low birth weight or smaller than average length newborns. Most newborns have spontaneous descent of their testes during the first 6 months of life. And make sure that you know that children with undescended testes are at increased risk for testicular malignancy and infertility. And that exposure to the testes to the heat of the body leads to low sperm counts at sexual maturity. So it's a good history taking, especially if a young man comes in and they haven't been able to have children. So that would be one question that you would ask. Remember, they also are at greater risk for torsion and trauma, frequently associated with an inguinal hernia. And the clinical manifestations, the testes are not palpable, nor are they easily guided into the scrotum. And we can, when we look at our diagnostic evaluation, we look at whether one or both of the testes have been undescended. If the testes is not palpable, in some instances we'll go ahead and do an ultrasound, CT scan, MRI to determine the location. And it's interesting because the missing testes can be found at any point along the process vaginalis, which may be located in the abdomen, or it may follow an apparent course and come to lie in the inguinal area, maybe the base of the penis or the perineum. It can also be in the intra-abdominal. We may find testes which may require exploratory surgery by lap, or an orchiopexy may be performed. When neither testes can be palpated, the child may be evaluated for their presence by hormonal stimulation and the measurement of testosterone response. If they have an elevated FSH and LH levels accompanied by absent testosterone, that could indicate testicular absence, and true absence of both of the testes is very, very rare. Well, initially, the infant with undescended testicles is managed by observation, because usually there's that spontaneous descent during the first 6 months of life, and that's very common. If the condition persists, they can do an orchiopexy, is performed to bring the testes down into the scrotal sac and suture it in place. That's usually done by lap approach, and the most common complications to that surgery is bleeding and infection. The optimal time for surgery is usually up to the physician. They usually say that increased frequency at 6 months of age is common, but no later than ages 9 to 15 months of age. And the purpose of that is, of course, to reduce the risk of infertility and malignancy. And it's always important to teach the male adolescent to perform testicular self-exams throughout life to screen for any kind of malignancy. So our nursing care of this child will, under our nursing diagnosis, is deficient knowledge, especially parenteral, related to the cause and the management of undescended testicles, and the risk for ineffective health maintenance related to possible decreased fertility and increased risk of testicular cancer or malignancy. So under our nursing care, it should be directed at educating parents and providing them with information and resources. And if the child has bilateral undescended testes or absence of testes, make sure to refer to a counselor, psychologist, or a specialist may be appropriate. It's important to monitor after an orchiopexy the patient's voiding patterns at the pain level of the child or the infant, and swelling or any signs or symptoms of bleeding or infection. Now we're going to be talking about vesicoureteral reflux, and just remember of the anatomy that there's a wave-like mechanism at the junction of the ureter and the bladder, which prevents urine reflux into the ureters. So as urine fills the bladder, or as the bladder contracts during voiding, pressure in the bladder occludes the opening to the ureter, so we don't have reflux. But when a defect occurs at the vesicoureteral junction, then we'll have what they call VUR, which is vesicoureteral reflux. And that results from that. That's that primary reflux, usually from a congenital anomaly that affects that junction. Secondary reflux can be associated with a lower UTI, is also possible, and that's just transitory VUR. Reflux with infection is the most common cause of pyelonephritis in children, and it's the same type of signs and symptoms that we see in UTI. And you may see those clinical manifestations of pyelonephritis, which is more of a systemic infection than a UTI in the bladder. On page 461, there's an international classification of reflux, and it's graded. It shows you the normal on the very far left top, and it shows you the mouth. There is a valve from the ureter into the bladder. And then grade 1, you'll see there's reflux up into the ureter only, and there's no dilation. Grade 2, we see reflux into the ureter, the pelvis, the calces with no dilation, and normal calceal fornices. Grade 3, we have mild dilation of the ureter and mild dilation of the renal pelvis. And then grade 4 and grade 5 are worsening refluxes into those into the kidney. You don't have to know the international classification of reflux, but you can appreciate, I think, from this picture of the severity if untreated, and which would lead to kidney failure. So it's divided in, this slide just goes over the division of the different grades of vesicoureteral reflux, and there's grade 3, 4, and 5, as mentioned before, and you can see on page 461. Here's some diagnostic tests that they'll do. They'll do a urinalysis and a urine culture, do electrolytes, BUN, creatinine, imaging studies. Usually plan about 3 to 6 weeks after the infection to allow for any infectious inflammation to subside. Then they'll do an ultrasound avoiding cystourethrogram. So this slide kind of gives you some ideas of what they do with the different grades. Grades 1 and 2, they do continuous low-dose antibacterial therapy with frequent urine cultures. Grade 3 is managed with antibiotics unless complications are present. And then grade 4 and 5, excuse me, grade 4 and 5 may require surgical intervention. So nursing considerations: explain the treatment plan, help the patient and family with that treatment plan. Explain that medical management may last for years. Adherence to antibiotics is very, very important. And if surgical intervention is necessary, educate, pre-op and post-op repair. And that will come from your physician orders. Okay, we're going to stop at this one. Just wanted to refer you to page 463. It's a patient-centered teaching and how to manage and prevent urinary tract infections. And this is great teaching for our parents, and making sure that they do prevent urinary tract infections, and how important it is to follow up, make sure that antibiotics are given for the full number of days that's been ordered. Usually they have to have a follow-up urine culture to the lab, especially if the physician or nurse practitioner has requested one. Keep the follow-up appointments, and make sure that you call the nurse practitioner or physician, the healthcare provider, if the child has a fever or any symptoms that may make you think that the infection has returned. Preventing UTIs from recurring is important because repeated infections, as you know, can cause kidney damage. And here's the suggestions are bulleted in the box under patient-centered teaching. But make sure you teach parents to wipe babies and teach young girls to wipe from front to back after going to the bathroom. Make sure to keep the foreskin on uncircumcised baby boys as clean as possible. Encourage your toilet-trained child to avoid holding urine and to urinate at least 4 times a day, and completely emptying the bladder Parents are told to give their child lots of fluids throughout the day to help flush out the bladder. Avoid dressing the child in tight clothing or diapers. Use cotton underwear rather than synthetic fabrics. Avoiding bubble baths, which can irritate the urinary system. And emphasize proper hygiene, especially if they have a daughter who's sexually active, and encourage her to urinate immediately after sexual intercourse. And then we'll go on in our next web link onto some more congenital abnormalities. Now we're going to be talking about the pediatric disorders with a genitourinary alteration. This is the anatomy of the genitourinary system in a little girl, and she looks about age 4 to 7 maybe years of age. So you can it tells you a little bit about the placement of the kidneys and the ureter and the bladder. There are some differences in the genitourinary system. Complete maturation of the kidney occurs usually between 6 and 12 months of age, and before this time the filtration capacity of the glomeruli is reduced, so urine is voided frequently and has a very, very low specific gravity because of that glomerulus filtration rate being reduced. So it's like they can't concentrate urine. Fluid constitutes a larger fraction of an infant's and small child's total body weight. The kidneys are less efficient at regulating electrolyte and acid-base balance and eliminating some drugs from the body. The maturity of those renal structures predisposes the infant to dehydration and, of course, fluid volume excess. Bladder capacity increases usually from about 20 to 50 mLs at birth to about 700 in adult. The innervation of the stretch receptors in the bladder wall does not occur before the age of 2. So that kind of gives you an idea that when that at least has been matured, you're going to have that child feel that sense of fullness. So, and before that, they won't. The urethra is shorter in children than in adults and may contribute to the frequency of UTIs that you especially see in children. Kidneys are more susceptible to trauma in children because they do not have as much padding as you and I do, as we all know. Well, especially me. I don't know about you, but especially me. So some of the diagnostic tests and assessments of the renal system that you'll see, of course, is the urine specimen for analysis. It can be a clean catch or it can be a sterile. IVP, radiographs of the kidneys, ureters and bladder, renal bladder ultrasound, cystograms, CTs, voiding cystourethograms, and MRIs. On page, this is chapter 20 in your PEDS book, The Child with a Genitourinary Problem, and on page, let me just refer you to it real quick, is the common labs and diagnostic tests are on page 456 if you wanted to follow along. But I think it's important that you have a basic understanding of what's normal for specific gravity. And if it's high, what does it mean? And if it's lower, what does it mean? The pH sometimes is altered by diet. Usually it's 4.5 to 8. Glucose, detection of glucose in the urine. We should not detect glucose in the urine, and we really want to make sure that we do just a simple urine dipstick, especially if the child has been having problems with enuresis, nocturia at night. Make sure they're not a diabetic. We want to check for ketones, and children are more prone to development of ketouria, so we want to make sure that that's negative. Leukocyte esterase, that's just the enzyme that is released during the white blood cell breakdown, and that should be negative. If it's positive, it may indicate that there's a possible UTI. Are nitrates produced by select bacteria that should be negative, and when it's positive, it usually means that there's some bacteria in the urine. White blood cells, usually seen with infection. Urine culture is usually indicated for that. Red blood cells, it's very normal in menstruating females, but it could mean that there's trauma, stones, infection, or glomerulonephritis. Bacteria, there should be none in the urine, and if there is, it's indicative of a UTI, and a culture should be done to see what kind of organism and what sensitivity there is for which antibiotic. Casts are just WBC casts and red blood cell casts that originate in the kidney tubules. Usually indicate if they're present pyelonephritis, glomerulonephritis, some kind of renal infarct, collagen disease, interstitial inflammation of the kidney, and urine, of course, urine culture and sensitivity, presence of bacteria. It should be negative or less than 100,000 colonies per ml of urine from the clean catch or a sterile specimen. Usually, if it's indicated, there's isolation and identification of pathogens in that urinary tract, and then there's identification, of course, of antibiotic sensitivity. Serum studies, of course, will BUN. That's the end product of protein metabolism, blood, urea, and nitrogen. Nitrogen's that end product, and usually increases in renal insufficiency. Your serum creatinine is byproduct of muscle metabolism production, and it's usually constant as long as the muscle mass remains constant. And it should be assessed before giving any kind of nephrotoxic type agents. And of course, as you know, it increases in renal insufficiency. It goes into the different radiographs, your kidney, ureter, and bladder. Cystoscopy, and they go up and they examine the bladder and the lower tract to see if there's any tumor or stones. Of course, CT of the scan, CT scan to check for any renal tumors. Voiding cystogram, voiding cystouretherogram, it detects reflux of urine into the ureters and its severity, so that at that VE junction we talked about the other day. Renal ultrasound assesses the position, the size, the contour of the kidneys and the ureters. And any kind of urodynamic studies can be done for any voiding dysfunction and any abnormal urinary tract problems. And that's on, as I said before, it's on page 456. It starts there. These are the serum blood tests that may be done. We've already talked about BUN and creatinine, and we haven't talked too much about serum electrolytes, but as you remember, the functions of the kidney is the production of renin, which helps with the regulation of blood pressure, and release of renin is stimulated primarily by the decreased pressure in the afferent arterioles of the glomerulus. Remember also that the kidney functions to produce erythropoietin, which stimulates red blood cell production by the bone marrow. And it also metabolizes vitamin D in its active form, which is important, especially with calcium. So those may be some red flags for us as we look at our serum blood tests, but know that there are a lot of other differentials that you have to think about as well. Okay. We're going to start talking a little bit about urinary tract infection and vesicoureteral reflux. It's that word I can't hardly say. Anyway, UTIs. UTIs, as you know, we've talked, hopefully you've listened to the lecture on Chapter 69 in IGI, but it's caused by bacteria that ascends from the outside, the urethra, into the bladder. And from the bladder, bacteria may continue to ascend into the upper urinary tract. Usually fecal bacteria is most common cause of UTIs, and that's probably approximately 80%. So here are some of this slide goes over some of the anatomical and physical factors that predispose to urinary tract infections, and they include females because of the short urethra, which provides a real ready access for invasions of different types of organisms. The males, there's increased incidence in uncircumcised infants, especially younger than 1 year of age. There also could be the child could be predisposed because of urinary stasis or the vesicoureteral reflux, sexual activity in adolescent girls, any kind of urinary tract obstruction, and constipation in the child can also cause a UTI. This slide just goes over the different signs and symptoms in the infant versus the child. So we'll first start with the infant. Fever, they may have hypothermia in the neonate, irritability, difficulty urinating, change in urine odor or color, poor weight gain, feeding difficulties. In our child, the clinical manifestations may be abdominal or suprapubic pain, voiding frequency, voiding urgency, difficulty urinating, new or increased incidence of enuresis, that nighttime bedwetting, and the child may or may not have a fever. Under our diagnostic evaluation, we're going to get the history from the parent. We'll do our physical exam, do a urinalysis, and do a urine culture and sensitivity. And our therapeutic management will eliminate that current infection, identify any contributing factors, especially if the child maybe has constipation, predisposes him or her to UTIs. We want to prevent urosepsis, and we want to preserve that renal function. Very, very important. So our nursing considerations, we want to monitor I&O, we want to observe for signs of dehydration in the infant and the child, administer antibiotics as ordered, obtain daily weights, encourage frequent voiding, especially in the toilet-trained child, because as children, they'd rather play than pee. Or poop, so want to make sure that we remind them, especially, I love how kids always, kind of dance around, and you can always tell the hand goes right down to the genital area, and that they have to go potty, but they just don't want to take the time to do it, so it's really cute. Anyway, we also want to encourage increased fluid intake, very important, and it's important to educate the child and family as well. We're going to take a break right here, and we'll continue on another web link for the vesicoureteral reflux. Okay, talk to you in a minute.